Good morning, everybody. Thank you for joining us for another episode of Treat Live at Mount Sinai. We have a great case for you today, but before we jump into that, I'd always like to start by thanking all of our partners that make this possible. Broadmade AV, who are help us with all of our recordings, our editing, our patients, first of all, and also all of our team here at Sinai. So before we get you to the lab, I would like to introduce my co-moderator for today, Dr. Joji Barakancheri, who is an interventional radiologist at Kaiser in Los Angeles. Hi, Joji. Thanks for joining us.
Yeah, thanks for having me. Excited to see the case.
So without further ado, let's get to the lab with Dr. Patel. Rahul?
Hi, can you guys hear me?
Yes.
Yeah.
Okay, perfect. So again, my name is Dr. Rahul Patel. I'm one of the interventional radiologists here. To my right is Dr. Ishan Sinha, who's one of our PGY6 IR/DR residents. Again, as Karim said, I'd like to thank our partners, Broadmade AV, our wonderful nurses and techs and patient, and also the patient for allowing us to share his case, and as well as our anesthesia services for helping make these cases go smoothly. So without further ado, I'm going to actually ask Ishan to introduce the case, and then we'll get going.
Hey, good morning, everyone. So today we're going to be doing a case of hypogastric artery embolization. Next slide, please. So our patient is an 84-year-old male with a history of AAA. That was status post-endovascular repair back in 2014. He's also got some cardiovascular history, including CAD status post-CABG, mitral valve disease status post-replacement, and prior stroke. He had a surveillance CTA showing an enlarging aneurysm sac and likely type 1B endoleak related to a right common iliac artery aneurysm. For relevant meds, he's on the half dose of apixaban BID, as well as some cardiac and cholesterol medications. Next slide. So in terms of his interventional history, preoperatively prior to his EVAR, we did an abdominal angiography and IMA embolization. He had his EVAR done in January of 2014. He came back to us in May of 2017 for a type 2 endoleak embolization, where we embolized the right L3 and L4 lumbar arteries. And in August of 2023, we brought him back for diagnostic angiography, which showed an incomplete seal along the distal right common iliac artery stent without an endoleak at that time. Next slide, please. His exams and labs were grossly unremarkable. He was a little hypertensive, but otherwise his femorals and pedal pulses were good. His abdomen was soft, and his labs were all within normal limits. Next slide. So this is his most recent CTA, chest, abdomen, pelvis from March of this year, if you could play the video. So as we scroll down, we see he's got somewhat tortuous aorta with atherosclerotic disease. He's got some variant anatomy with a common hepatic coming directly off the aorta. And now as we get down into the EVAR, you'll start to see the aneurysm sac on the left as we get to the iliac limbs. The sac measures up to almost 8 centimeters in AP dimension, up from 6 centimeters previously. And if you focus on the right common iliac artery, you'll see a little bit of aneurysmal dilatation, better shown on the right image, with filling of contrast on the medial border of that stent there. Next slide, please. These are two coronal reformats of his CTAs from September of last year and March of this year. As you can see, the aneurysm sac has increased in both the transverse dimension, and then, as I mentioned before, it's also gotten larger in the AP dimension. So there's concern that, this endoleak is causing pressurization and enlarging sac. If you go to the next slide. In summary, this is an 84-year-old male with significant cardiovascular history, including a AAA status post-remote endovascular repair and endoleak embolization, now presenting with an enlarging sac, likely due to a type 1B endoleak in the setting of a right common iliac artery aneurysm. The plan is today to do a right hypogastric artery embolization via radial approach as a staged procedure prior to extension of his right common iliac artery stent into the right external. That's all we have.
Perfect. So Joji, you do a lot of EVAR. So it was originally a Gore device. I mean, it's kind of something that we see. I think EVARs just sort of, in essence, are kind of like a Band-Aid, right? They basically seal, but the process that leads to aneurysms is still going on in the vessel wall, right? So we see sometimes we'll see this degeneration of the neck or even the distal seal. So I mean, you do a lot of these. Do you see this frequently, or?
Yeah, you're going to get anywhere from ascending to iliac or a disease. So you're going to have progression. So EVAR 1 showed that in 50 years that you're going to have increased aneurysm-related mortality. So you definitely need to follow them. They're going to degenerate. So now we have devices both distally, but even now proximally that we can kind of fix these paravisceral components or thoracic components. So it's good to have new endovascular options instead of open repair for these. But yeah, it is the bane of uh, endo, but even open has a degeneration as well. So it's not
Yeah.
it's not free, but yeah, definitely have surveillance these.
And Rahul,
Yeah,
let's talk a
so
little bit about your choice of access.
yeah, so Ishan right now is getting radial access. So we numb. He's going to use the needle to get in. I don't know if you guys can see the ultrasound. So he has a nice big radial artery. He's had that right groin accessed a couple times. He's going to get it accessed one more time to get the limb extension placed later. So we figured we'll just stay out of it for now. And it's also a little bit easier to get into the hypogastric from above, right? It does somewhat limit. It used to be able somewhat limit what we can place. Like it's a little bit harder to place like an Amplatzer plug from the wrist, but but it's easier patient comfort. And then again, like I said, they're gonna have to go back into the groin in not short order here, so to put the limb extension in. So that's kind of why we're doing it. So again, in terms of radial access, again, it's we'll sort of like a shallow angle into it. We did check a Barbeau beforehand. It was a Barbeau B. John's getting stuck there. So yeah, and then we'll go from there. If we did prep the right groin just in case. Sometimes these patients are taller on the inside than they are on the outside, but I think we'll actually be okay, and go from there. So Joji, and his case is a little interesting. Is that we see this degeneration of the right distal extension, but the one thing we don't see is a really big obvious leak. His sac is growing slowly over time. We've done an angio before. We didn't see a leak. Yeah.
I think that's not uncommon, unfortunately, with these kind of type 1s. We'll think they're type 2s, but they're really type 1s that just kind of occult. So I always look for circumferential seal in either the proximal neck or the distal limbs. So I want 360 with contact for a centimeter or so. Otherwise, I'm really worried that it is an occult type 1 as the problem with that growth.
Blocked. Yeah, exactly. So, we did the angio before. We looked for another type of leak just to make sure. Going easy? Mm-hmm. Okay. Yeah, to look for another leak about a year or two ago, and he did okay. And we didn't see any, type 2 endoleaks. And so now this is kind of what we're left with. His sac is now grown to, 8 centimeters. And so it's fine. So I think we have to bite the bullet, and extend him.
I have a low threshold to do this, right? To take out the hypo and extend makes a lot of sense. If the other thing you could do, depending, is like sometimes we'll put an IBE, iliac branch excluder, and Flores went and Cook just came out with it. That enables you to preserve the hypo depending on the ipsilateral limb. So there's ways to kind of do that IPSI approach from combo radial brachial.
Okay, you can go.
So, Joji, can you talk about that a little bit more, Joji? The options we have here. So here, it looks like the plan here is to do a staged approach, but then you're talking about iliac limb. Can you kind of give us the options and run us through them?
Yeah. So I mean, again, I think hypogastric embolization is fairly safe, especially stay proximal to the anterior posterior division. They will probably have some buttock claudication up to 40%. Pelvic ischemia is a possibility, but low likelihood. You did end with the IMA, but still, I don't think that will be usually an issue. And again, pretty well tolerated. I've even done staged bilateral hypogastric embo, so I think it's very reasonable. But we can also do preservation of the hypogastric, and depending on the diameter of the limb, we have a Gore 23 graft has a 23 proximal. It's 3 centimeters to the bifurcation, and then a 2.5 for the hypogastric.
Radial cocktails going in.
Then a 10 centimeter, 12 centimeter, or 10 centimeter long IPSI side. So you could deploy that, and it's a fairly flexible stent. And provided you have about 5.5.
Regulate the side flush, please. Can we regulate the side flush? Can I get a 465?
Or radial, put a VBX and stent into the internal. So that's another option for repair if you want to preserve the hypogastric. But
Yeah,
again,
so his limb is 12 millimeters, right? So it would be really hard to put a iliac branch in that none of space. So
yeah,
I don't know if you guys can see the
14 or 16 to do that, but yeah, I agree. 12 is too small for that.
Yeah. So I don't know if you guys can see on the fluoro.
We can.
Yeah. So there's it looks like there's a radial loop.
Wow.
So we're gonna. I think it should be okay. It looks like a pretty big loop.
So let's go through this. I mean, you guys obviously have a lot of experience with this. Do you kind of ultrasound it perioperatively to look for this?
So, when we first started doing radial, we actually did like an experiment where we just pre-op ultrasounded 50 patients to look for a radial loop, and we didn't see any, so we stopped doing it.
And how do you explain to everyone what a radial loop is, how you can get in trouble with it, and how do you navigate around it?
Yeah, and go forward. Yeah. So it looks like our sheath is a little occlusive, but that's okay. It's actually not so bad, right? It's just tortuous. Yeah, it's not really a loop.
But Rahul, like Joji was saying, can you just take us for the people who don't tend to do a lot of radial?
Yeah. So if it's a tight loop, if it's a very tight loop, you can usually just wire it, right? And
get out. J glide, or what do you use?
Yeah, you can use a J. Here we're using a glide, but here he's just got floppy vessels, right? You kind of see it in older patients. You can just take it across and we'll switch it for the Benson. Yeah. So, and then what you do is once you get across with the glide cath, you usually you can stop there. You'll put a stiff wire, and you can actually pop it straight. Now, some patients won't tolerate it. So you'll have to give either extra pain medicine or an extra cocktail, just because it causes a lot of spasm. But in this case, he'll tolerate it fine. Oops.
And then can you do kind of pre-op, cross-sectional imaging of the kind of arch subclavian, or kind of is there a guide
we looked at it.
Okay.
Yeah, we looked. We're gonna switch this out right for this. I'm gonna just take the Simmons. Yeah. We look at the arch just to make sure there's no disease, especially if we have imaging. We're not getting pre-op imaging on these patients typically of the chest. We haven't really run into issues. Obviously, we'll look at blood pressure and stuff like that. He has a booming radial pulse, so I'm not really worried about a subclavian stenosis or something like that. But yeah, so that's kind of how we do it. Older patients, the arch tends to be a little bit more tortuous, especially in someone who already has an EVAR, aneurysmal disease. So instead of going with a Sarah and trying to muck around too much in the arch, we're just going to take a Simmons. And
then Rahul, you've mentioned the cocktail twice. What's in our cocktail, and what's it for?
Yeah, so the cocktail is basically to help keep the radial artery open. That doesn't want to go. Oh, there we go. So our cocktail, and whatever you want to use as your cocktail, you just use that, right? So ours is 200 mics of nitro. 2.5 mics of verapamil, 2.5 milligrams of verapamil, 200 mics of nitro, and 3,000 of heparin. Oh, not all the way in yet.
So an easy way to remember that is 2.5, and 3. So we do 200 micrograms of nitro, 2.5 milligrams of verapamil, and 3,000 units of heparin to prevent spasm and keep that artery nice and open. Okay. Seems like
so
you got it down.
Is that a Sim 1 you used?
Sorry, yeah, it's Glide Sim 1, right? Just to get down. Yeah, just to get down the arch. You can usually get down with a Sarah. We might have been able to get down, but I just didn't want to do a ton of exchanges around his arch. So, this is just, and we just use the Benson. So I tend not to, try not to use a glide just because it can get, you don't want to dissect or anything like that, especially in someone who has a lot of calcified disease. So Benson's pretty forgiving. You can shove it pretty safely,
So usually, our go-to for getting down the arch on patients without a tortuous anatomy, it's usually a Sarah, and the Simmons one, kind of like a troubleshooting microcatheter. You can kind of take it downform it, and then it'll hook. If there's a lot of tortuosity, it hooks the descending. So
Let's
it's
do this.
a nice trick to know.
You form the sim one in kind of the ascending slash arch.
Correct. And the kind of the ascending, and then once you're coming up the arch, if you can
Right down the right.
imagine,
Yeah. So just keep that right.
the reverse
take the
curve
Sarah
actually hooks on the descending, and it's very nice. It works really nicely.
And then, one of the challenges sometimes we'll have in some of these thoracoabdominal is the tortuosity and length of the thoracic. In this case, it doesn't seem too bad. But when you have a lot of elongation, it seems a lot of length, unfortunately.
That's what Rahul, I think, was saying earlier.
That there, you can. I call that being taller on the inside, than you are on the outside. But he's okay. So we'll do
for a run.
Yeah.
And it's interesting. I mean, it sounds like had a lot of extensive work. That you did a prophylactic inferior mesenteric.
Yeah, we sort of a throwback from when we did more of these. We used to do diagnostic angios, and then we would embolize the IMA, especially in patients with big IMAs. Can we go forward on the injector? We did. So this is Sarah. So Sarah has side holes, so we can power inject it with sort of. And obviously, we're in the limb. So yeah, we used to with patients with like big open IMAs. There's some data to show that it decreases the rates of type 2 endoleaks. Although again, this guy still ended up with a different type 2 endoleak and a type 1B. Although it's not so bad. It's like a 12-year-old graft, right? So he's really only had 2 interventions.
And then Rahul, sorry, I know you're ready. I know you're ready to do a DSA, but can you just take us back and
20.
let's look at what all the hardware the patient has?
Yeah, so he has a Gore. So the original device is a Gore endograft. I'm sorry. Yeah, sorry. You want to see?
Yeah, I know you're ready, and you're ready to put just
Here.
Great.
This is a little bit of an oblique, but you can see the Gore endograft. The left side sealed down into the common iliac. The right side also sealed into the common iliac. So he's got some coils in an IMA, and then we put some onyx in when we did the endoleak, and then it coiled out the lumbar artery, and then you can see the coils in the IMA, which are sort of arching to the 3 o'clock position there. We're good?
Great, thank you. You may proceed.
Yeah. Thanks. All right. I think you're good, right?
I'm good.
Yeah. Cool. All right. You guys want to step out? We're going to do a run. So we're just going to step here in the corner.
So sometimes what I'll do to kind of work these up is get an MRA with subsecond coronal imaging, so twister tricks. And that way sometimes you see the angiographic flow pattern. Or contrast enhanced ultrasound I've started to use a little bit for these kind of occult leaks. Yeah. Oh, interesting.
Yeah, you can see the leak there, like it's coming up, but I don't see a leak into the sac itself, which, as I think Jojo was saying, you can stop. It ends up being like a ball valve, right? That it's not open all the time, and it's like this slow leak. So his sac didn't have like a rapid expansion. It's slowly growing, and then this is clearly not sealed. If we didn't show you what it looked like before, but when it initially was placed, it was well sealed at this end. So we have the Benson. So,
the other thing is what's interesting, if you look at a lot of the trial data, the legacy trial EVAR 1 or EVAR 2, a lot of these patients died of cardiovascular events, and I think you guys done a good job in putting them on a kind of dual kind of anti-cholesterol with the rosuvastatin and ezetimibe. I think that's to get the LDL lower probably is reducing event rates. Kudos to you guys for that.
Yeah, he's actually he's a really healthy guy. He's a drummer in a band. For his age, he's doing great. Yeah. Pretty active guy. So they're
sometimes.
So now obviously the Sarah's. Well, yeah. Go ahead. Sorry.
Sometimes the lip of the graft, it can be tricky to cannulate the IPSI internal, depending on how low the limb is or how angled it is. And so it's sometimes a little tricky to get in either from an IPSI approach or even probably from a radial, from an angulation standpoint.
So you tend to do femoral on these, Joji?
I do tend to do a transfemoral approach. Yeah, because what I'll do sometimes is if I need to, I'll even form a tour guide, like a cerebral sheath if I have to. But typically that's what I will do. But I think a transradial, transbrachial, if you want to put a plug, is also very reasonable. And as Rahul was saying, you kind of get into some length issues, which can be tricky, and diameter issues. But many of the plugs, I don't know what this measures diameter-wise.
This is
1050.
an 8.
Oh, 8. Okay, yeah. I
Yeah.
mean, you could probably get away with a 6, sheath and a 12 or so plug. So that is an option. Again,
Stamping glide
length
wire.
could be an issue, but it is something that may work.
And then you're talking,
Yeah,
Joji, you were talking
I
about, sorry, go ahead, Rahul.
yeah, I've had some bad experiences pushing Amplatzer plugs from the wrist, especially through a guide, because the long guides from the wrist are kind of short, or sorry, kind of soft, not short. And in terms of recapturing them, I've gotten burned once, so I'm kind of like a little shy. But the Amplatzer 4s, we've been okay with those going from the wrist.
How about I'm curious, have you pushed an Amplatzer AVP2 through a R2P sheet?
I haven't, so that probably would be okay, right?
That's what I'm thinking.
Yeah.
But
So
you're
Joji,
right.
going back to navigating the tricky anatomy, and can you just give us? You said you tend to sometimes choose transfemoral access.
Yeah.
Any specific catheters that you like to kind of help?
So it really
navigate
depends on the angulation, how tight. Sometimes I'll form it in the limb, like a reverse curve, and try to pull it down. I may even convert to like a micro system, or I'll have a 6-point, like an Ansel, like curved Ansel 2 or Ansel 1.
Like cooking, huh?
Then that'll give me support, and I'll drive it in. Sometimes even a Comfy works. This angulation, if you see, is broader, so I think you can get away with more. But sometimes, like even a Comfy, a 40 or 65 Comfy will track into that, give you adequate support to do it. So really, it depends on where the limb is hitting, how distal the limb is compared to the hypo, and the angulation. And you see, he's coming off
a lot of
greater curve. So he's pushing. He has to push off the greater curve to get in, but he's got pretty good.
That looks good. Yeah.
Support there.
We're in.
What do you got in there? What's your guide and
So
wire?
this is so the diagnostic catheter is a 4-125 VER, and then we just used an LT glide, so a long taper 150 centimeter LT glide. If this doesn't work, then I would actually switch to like a microcatheter system and then try to do like a try to use the micro wire because you can shape it. Yeah. And but now that I'm all the way down, I could. Yeah.
No, I think it's great, and I think in these cases, there's even back in the day of Cinnamon, like he published the kind of what's your kind of approach as far as trunk embolization versus divisional embolization, etc.
So yeah, my plan is I think there's very good data to show as long as you stay above the anterior and the bifurcation of the anterior iliac, they do better, right, in terms of symptomatology, in terms of buttock claudication and recanalization. The other side's open, so my plan is to just do the hypogastric artery. So the problem here is that it's an 8. So if I were going to put an Amplatzer plug, you got to upsize, right? So you have to, they recommend a 30 to 50% oversize, which means I have to put like a 10 or a 12, right, in there. And so then I have to switch to like a 5 or 6 French guide, which, in terms of length, we would need all of it. We would need a 120 guide, right, to get there. So you could use a 119 R2P sheath and do it through that. But I think what we're going to do actually is Penumbra has these new 035 coils, which we're going to use to see if we can. It's like basically their 035 version of their pod, and so we're gonna use that today.
Yeah, we had Andrew Club in LA yesterday, and one of the cases, the presentation of that 030-inch diameter coil, which is pretty impressive in the volume.
Yeah, so the coils for Penumbra, they're sized a little differently. They're supposed to be 1-to-1 sizing for the pods because it's a relatively stiffer coil. So we're going to take an 855 pod. There is an 870. The only reason is I don't have a ton of experience. So I'm a little worried about because it's not a super long hypo. So I'm just a little worried about the length. So I can always put an extra coil. It's really hard for me to to shorten the coil. So we're going to try an 855 and see how it goes here. In reality, I'm hoping that it just takes 1 or 2 coils and we'll be done.
And I think that's a
Yeah.
good strategy. So the interesting about that kind of pod thing is you have a high radial force coil that comes out
Right.
first, and a very soft kind of like a
Yeah.
spaghetti that fills that holes and intersperses. So it's kind of nice to have that. And I think it's wise to kind of like, well, you always can put packing coils behind that network.
Yeah. Yeah, and so these are sort of their new 035 coils. They're actually 030 outer diameter, so it's the largest volume coil on the market. There are only about 2 or 3 detachable 035 coils out there. So it's either this one, the Terumo, or I guess technically the Retracta, the Cook coil is fully retractable. The 035 interlocks are great. The problem is that it's sort of this passive detachment. They're a little bit stiff, so sometimes can be a bit tricky. So I don't know if you guys can see. This is how the coil comes. It looks exactly like their normal pod coils. The only thing is it comes out a little differently from the hoop. So we're gonna unlock this. I swear to God, I can unlock this. Yeah, here we go. Yeah, it comes up. And so it comes out front end first. So you're going to get this. It comes in this sort of orange casing. And then it comes out there. There's no friction lock that's sort of on the other one. So it will slide in and out. Can you just hold this for a second? So you saw the run, Joji. I think we're in a good spot. We're going to kind of land it here. If a little coil goes right on top of the bifurcation, that's okay.
Fine.
Right?
No,
yeah, we just don't want it to go. Yeah. So here we're going to marry the two together, and Ishan's going to help me load it. Yeah, go ahead.
Can we see the fluoro, please? Thank you.
The fluoro. Oh, it's okay. Okay, so we're going to take this out. We're going to save this orange hoop just in case if this coil doesn't work. We can always re-hoop it. I'm going to mag up a bunch just so you guys can see this coil come out. Here it is. Man, that is a huge coil.
Yeah.
Yeah.
I'm going to
form the coils pretty well there. I like it.
Yeah. Yeah, that's perfect, right? Give it a little room here. And now we should be into the softer packing portion of the coil.
Yeah, looks like it.
And you can see kind of like the undulation more proximally in the limb of the coil.
Yeah.
Oh, yeah.
Oh, very nice.
Yeah.
That worked great.
And we are out. Okay, so the coil is out. So the detachment mechanism is still the same. You can actually use the same handle that you use for the regular penumbra coils. So it's this sort of, I don't know if you guys can see it, it's this click back. So you basically marry the coil into the detachment mechanism. You hear the click, it's detached. I don't know if you guys can see it well. There's a black mark and then it's solid, and when you detached, there's a little black piece that comes apart. So you'll see the two pieces come apart, and then it should be detached. Yeah.
Nice.
Yeah, so that coil is out. So it's nice and out. Probably need one more coil, I think. So there is a packing version of the coil. So we'll take the short 30. Yeah, so we're going to take the 30 packing here. So here, I'm not worried about this angle anymore. I'm worried. I'm going to switch back to the other angle because now I'm worried about the origin, right? So we have a little bit of length here.
And I think that's the key,
to the origin of the limb.
So
yeah,
the key is to kind of open up the anterior posterior division when you're deploying distally, and then the external internal bifurcation proximally and a below threshold to inject. So you see the external. If you get into trouble, the coils start to migrate in the external. You just trap it with the stent.
Yeah. Okay. And then while they're getting this ready, either Rahul or Joji. So you mentioned briefly claudication. We talked about 40%. Can you just tell us what's your conversation like with your patient regarding?
Yeah, I just tell them that you will likely have butt pain.
That's okay.
And their family as well. Like after the procedure, most of the time it resolves, is my experience, in about 3 months. But yeah, it's funny. The they always laugh when I say that or afterwards for whatever reason.
They might think you're joking, maybe.
No, I do think so, but for whatever reason, I just did one recently, and the couple, they were like kind of laughing at each other, but I'm like, no, that's because this pain is because of what we did. It's expected. So, and I told them beforehand, but sometimes just, in that conversation, they're hearing 100 things, so they may not even grasp a hold of it. Like, oh, he had a lot of butt pain. I'm like, yeah, that was expected. Oh, okay. And then, so I think it's just one of those things. But again, most of them resolve in 3 months. I have tried to loss solve. There's no data for this specific process, but majority of my patients resolve.
Should be good. Yeah, I agree. And we've seen it with, this guy, his other hypo is open, but we've seen it with just the unilateral hypo embo,
Yeah.
So this is a 30 centimeter.
Yeah. Right.
Yeah.
And I mean, I used to do
just the pack.
I used to do bilateral hypoembos, and so we published a small series in vascular disease management years ago. It was pretty well tolerated. I staged them 3 weeks, but now with IBs and all these devices, don't necessarily need to do that as much. But Mehta and Beath published a large series of bilateral hypos, so it clearly, nice.
Yeah, so that's out. So here we're going to deploy this. I'm not sure if I really need another coil. I think this should be it because it's a lot of metal in there.
Right, probably.
Yeah, some of it's also patience, right? Just yeah.
So most of these, like, it's not as critical to go for full complete occlusive thing. You can get burned occasionally where you have retrograde fill, but I think in a non-aneurysmal internal, you're probably fine. And then you're going to cover it so you'll have no inflow into it, and hopefully that kind of thrombose. One thing that I do watch out for is sometimes a proximal branch will come out these, so I tend to, like a iliolumbar may come off the proximal and the divisions. So I always look for that.
Yeah, I think we see one here. Yeah, I think we see one here. So. Let's see.
So in those cases, I'll get a microcatheter up and put a few coils, smaller coils, if that's the case.
No, I think we're okay. I think I'm getting fooled. Yeah, we may put one more. Do you have the glide wire? I'm going to try to shove this catheter back down and maybe put.
What are your thoughts? So it's pretty good packing density. What are your thoughts about now converting from 035 or 030 coil to a kind of the O2, I forget the diameter, the kind of the standard penumbra coils, or soft kind of intermediate diameter coils now, I guess, for penumbra, because they have the low profile.
Yeah,
not that.
Yeah, I think we could. I think we have enough space to put another like 30 centimeter packing coil. Yeah, just.
You can see kind of how the coils are bobbing, so you see the inflow. So
yeah,
not going to be fluid until the craft is in.
Yeah. Let's see.
But I haven't used this coil, so I'm kind of excited to see.
Oh yeah, see there's that branch that's going up, right? That superior sacral branch. But I think if we just put another packing coil, it should cover it. Can we get another 30? Yeah.
Sometimes the packing coils will go into that ostium, into the branch.
Sorry, what?
Sometimes the soft
coils they'll just just get into the branch. So I think we were having issues when you had to pull it out first, like so, and then pull it from the loop.
And then
Joji, exactly. They call it like liquid metal. Yeah. Go ahead.
Yeah.
So Rahul or Joji, when you're staging these, right? We're doing stage approach. How long do you wait? Can you just immediately, place the other stent and extend the limb, or what's your approach?
Great question. So it really depends on how complex the embo is, but oftentimes I'll just do it the time of. But if the floor time gets long, patient's uncomfortable, then it can get a little ornery. So I did one this past Monday where it was an IV device, but it was a hypogastric aneurysm. So I had to take out all the branch points, and so there's like 4 branches: 2 iliolumbars, anterior posterior division ostium that you have to take out, and then we went into anterior division ostium, and then deploy a stent to the supragluteal. So that takes a lot of time, and we just use conscious sedation. And you have like 16 French teeth in the groin, so it can be a little bit onerous for the patient and for the operator. So those are the ones that I sometimes will stage when it's going to be.
So that one packed.
Multi-branch embolization. But in this, you could.
That one
for
packed
example,
really nicely.
one thing you could do, say in this case, right? Say you wanted to go IPSI and ephemeral, right? I mean, radial would be a little tricky. You could put an RTP sheath and try to plug. Most of the stents that we use in this area are going to be like a gore limb. Minimum diameter is usually 12 French. So that way you'd have to go from transfemoral. But what you could do is you can go even 12. You could get an 8.5 guiding sheath. And then through that, I put a 6 French sheath and deploy the plugs, and then come back, go up to the limb, and then stent it. So there are a few options from that approach.
Yeah. So that one packed really well. So you do have to be careful, especially with the packing coils, because they're really soft. As you drag your diagnostic catheter back, you don't drag your coil pack back.
Right. And one thing sometimes I'll do is I'll put the Benson wire in, and then pull back the base catheter. So that it can't happen. You're right. I pulled coils in distal aneurysm sometimes, but it's so tight. So I'll put the 014 or the wire in, and then gently pull the microcatheter and pull the wire back.
Yeah. So this is gonna probably close. The question is, should we just wait, or should we just put another coil? I kind of like Joji's idea of switching to a smaller system, just to get maybe just put like a 60 regular packing coil, and then just sort of bury a microcatheter into the pack, right, to hold it.
Yeah.
Is that what you were saying, Joji, to try to do that? Yeah.
Yeah, exactly. I think you get into the interstices and then fill in the spaces between the, because it's still going to have space between those 030 diameter things, and you fill it with some much softer stuff. It doesn't even have to be long.
Can I get a 2.8 Prograde 150 and we get like a 60 regular packing? Yeah.
Yeah, I don't even know if you need length. You just need to fill the dead space.
Actually, although I think we might be able to, I think we have enough space. Maybe we can just get a regular 035 packing, another 035 packing here, right?
Yeah, I bet you do. Look at the brand.
It's going to be tight, right?
Yeah.
Yeah, some of it is that like that top little part of the coil pack isn't really packing anything.
Yeah.
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 Yeah, because it's just sort of floating in the breeze. Yeah.
So you are going to go with the micro system?
Yeah, I think I'm just going to go with the micro system and see if we get lucky, if we get into this little branch, because I think that's part of what's keeping everything kind of open. But we'll go from there. Yeah, some of it's just patience. You could also make the argument they're going to cover this anyway.
Yes, exactly. And that's often what I do. So it's not an aneurysmal internal. If it's an aneurysmal internal, different game. But in a non-aneurysmal internal, like it's pretty unusual for me to get complete obliteration. So unless I plug it. With the plug, it usually shuts down. Otherwise, we'll often see some flow and I put the limb in, and most of the time it's okay. It's rare that it'll have to come back from weird fundal collateral or something to embo or direct.
Yeah.
So
for an aneurysm, you mean?
Yep. Yeah. For an internal, the aneurysm is different, but for a disc, I think you'll be fine with just coiling and stent graft.
Yeah.
And then I know we've been discussing this, and I just want to take a little step back for the people who are watching. We're talking about adding coils, where to coil to. Just tell us, what's safe, what's our stopping point, how distal can we start?
Yeah, I mean, I think kind of the divisions is a great starting point, right above the bifurc. And putting that pod was a wise idea. I mean, the pod or high radial force coil there, and it worked out beautifully, right? And then you pack pretty aggressively with the floppy component and the packing coil.
And what's your stopping point?
Yeah, I think if you're not planning on putting the covered stent in, I would be more cautious of going too distal. So one other thing you can do, say you really want to, what you could do is you could kind of maintain this. You put your IPSI limb, right? You put your 12 French transfemoral. You deploy that, and you can finish coiling up, ad nauseum, right? So that's another technique I sometimes employ. Put a catheter,
just whatever you want. Yeah.
And then stent, and then finish coiling.
They have the lantern. And then can I get a fathom?
Rahul, any thoughts?
Yeah,
Since
so
you
I-
know we're not. Yeah, go ahead.
Yeah, so I kind of like that idea of just trapping it and then you can do whatever you want. You know, you can also switch to like liquid here if you wanted to. It's a little tricky, although hopefully it'll all get kind of stuck in the coil pack. Usually we don't tend not to do that. Maybe on aneurysms we'll kind of sometimes do that just because you get kind of bored shoving coils, you know, until the cows come home. You know, switch to like either thick glue.
Yeah,
we haven't
I
really
think,
done
like,
Obsidio.
honestly, even with this, you're going to be probably fine, right? You've shut down the anterior
Yeah.
posterior division. There is a little bit of flow into that thing that may retrofill, but I don't think it'll be a likelihood of it. But if you like throw a little bit into that horizontal portion, even a short, 20 or 30, and just kind of fill it, probably fine.
Yeah, I mean, part of it also is that he's on a Pixaband, like he's on blood thinner, right? So it's also making the coils a little bit harder to occlude. 150, yep.
And it's interesting, it's kind of that low dose of Pixaband, so which is becoming more and more popular based on Amplify Extend. I think Abicat was reduction of VT events. So we're going to see more and more of this, I think, even in the cancer population, compelling data. I think we're going to see more and more with low dose protocol.
Yeah, for sure. Yeah, we have a lot more patients coming in either on half dose or full dose, you know.
And we see a lot, I find these patients on anticoagulation, I don't know about low dose, but on anticoagulation for whatever reason, especially if they have a mechanical mitral valve or aortic, they have to have or mechanical mitral valve, especially the INRs are really high, these endoleaks sprout. So it's very hard
exactly. We've had which is, we've had this conversation. I mean, not you and I, but I've had this conversation with other people. Is about doing the angio on blood thinner, right? Because when you turn off the blood thinner, then it goes away, but then you turn it back on, and then it comes back.
You're right. I think that's a very good valid point.
Yeah. So
now,
here we're just.
If the patient's on warfarin and INR is doing that, do you anything different you do with the radial access or cocktail?
Nope, we kind of keep it the same. We haven't published specifically on blood thinner safety, but we have on patients with high INR and low platelets, and we haven't had any issues.
How low a platelet will you go to?
Unless they're actively bleeding, we've run with it. So, yeah. So you can see there, we've kind of buried the microcatheter. Yeah, now it's just going back out. Okay. So we kind of buried the microcatheter there. The one thing I do like about the Lantern or the 2.8 ProGrate 150 is that it has the dual marker, so I don't have to see the tip of the microcatheter to know
how far in.
Where. Yeah, exactly. So let's take So here we're going to take the smaller packing coil, the Penumbra 60 packing coil here. And sort of the same idea. Go ahead. We'll just load this up. Yeah, keep going. Good. Okay. We're just gonna fire this in.
There it is.
It's going in. You just can't see it because it's super soft, right? So.
Yeah, and it's not undulating.
There we see a little bit. Yeah.
So I always like that. There's not a lot of resistance yet. So there's a lot of space.
Yeah, which is again. Yeah, exactly. So you get fooled, right, looking at it as an AP image, right? That there's like, it looks well packed, but it's really not, right? So there's the dash. So we'll use the detachment mechanism again. All right.
So there's you're right. The volumetric analysis can be tricky. So I think there's like this house you can kind of utilize to kind of guide you to identify packing density online. So something to consider.
No, that was sailing.
I was like, wow, very
Yeah, now it's done, right?
Wow. Yeah.
That was injecting through the microcatheter.
Yeah, right. So you're not even injecting space, and you can see it's kind of sluggish to and fro. which
Yeah.
before with clothes are
Yeah.
kind of bobbing back and forth. I don't see that now,
Yeah, exactly. So
or less so for sure.
yeah.
Yes.
Oh,
Yeah,
yeah.
that's closed, right?
I think you're done.
Noted.
You know,
Yeah.
you
We'll do
put that stent graft, you're done. That's awesome.
exactly. Nope. We're gonna uncouple us.
Oh yeah, gotcha.
So I have
So,
two
okay.
questions for both of you. Well, let's finish. Let's do the last run.
Wow, that's pretty good.
Yeah.
That's very good.
Looks great.
Yeah.
I kind of
Yeah.
like that.
We probably could have. Yeah.
I feel like your technique of kind of putting the O3O and then the O2. I don't even know the diameter, but the intermediate coils now, I guess, in there.
Yeah. To fill up the rest of the space. Yeah.
Yeah.
All right. So we just took that out. So I think we're basically done. We're not going to put the limb today. We're going to do the limb as a separate staged procedure. So actually, we're going to show how we get out, just because hypo embo is not super interesting. But yeah, so we're going to show how we put the TR band. Can we get our regular?
Yeah, he's a regular.
Regular TR band. And we'll show you how we exit here.
Sizes of TR bands.
Yeah. So we use TR bands. There are obviously a whole bunch of different manufacturers that make these sort of radial closure devices. But so the Terumo's TR band comes in two sizes. It's regular and large. The large, I can't think of any patient who's ever needed something other than bigger than a large. I've never seen that.
Agreed.
Yeah, large is pretty big.
I agree.
Pretty high up the arm.
Yeah, unless you get sheet super high up the arm, which I personally would not recommend doing, just because you have to stay over the bone. But yeah, so what we're going to do, Ishan's basically, we're going to pull down the drape here. You want me to pull it this way?
Yep. 1 second.
So how do you decide between the two sides? Is there a wrist circumference or something that you utilize, or just like a stall?
Yeah, there's not a measurement. Just it's like a gestalt, right? Does it look big? The big will actually cover a lot of patients. There's a lot of overlap between the two sizes. So you could probably get away with a big if you needed to. Here's this TR band.
And then I know they have that proprietary syringe. How do you secure that in a way? So we send it to a PACU. How do you prevent that from being lost, so to speak?
So we'll tape it to the patient's chart. We used to tape it to the patient's forearm, but we just tape it to the patient's chart. Yeah, that is one of the more annoying things about the TR band is the proprietary syringe, because you can't just use a regular syringe. So if you lose it, you kind of either have to open up another band. I think it's a scam.
And then
so you're going to put how much? So again, so what he's done is he's put there's a green dot on the TR band, which he's placed over his entry point into the artery. It's a little hard to see, but there's a little green dot. And then he basically put the Velcro on as tight as he can, and then he injected about 20 cc's of air.
Still have a waveform.
Yeah, we still have a waveform here, so he's going to take out the sheath. It's a little hard to see, although you want the...
My Q-tips are up here. Yeah.
So sometimes when blood gets underneath there, it's a little hard to tell exactly if it's bleeding or not. So he's just cleaning underneath with a Q-tip here. And so now what he's going to do is he's going to slowly let a little bit of air until he sees blood coming out the arteriotomy, and then he'll just put in 1 cc more. And we'll leave it up. Some of these patients...
I like that technique.
Go ahead, Jody.
No, I like that technique because that's always kind of annoying. There's a bit of blood there, and I don't know. Right, so that little Q-tip.
Yeah.
I like.
Yeah, so we got about 14 cc's of air in there. So again, for these patients on apixaban, it may take a little bit longer. I tell patients, especially if they're on blood thinner, low platelets, or high INR, they'll get they're almost all invariably end up with a bruise. But the only time we really worry about the bruise is if it goes up above the elbow. And I'll be honest, we've been doing this for a long time. I've never actually seen it up above the elbow, so that's okay. And then sometimes they need extended.
Like above the elbow, you're worried about it? If it's above the elbow,
if the bruise, that it can be turned into a compartment syndrome, because it's starting to break out. But I've never seen that, So
yeah, I've never seen that.
And so this will so this will stay on for about an hour and a half. That gives them enough time to recover in our recovery area. and then we'll take it off slowly. So usually we'll let out a few cc's at a time over a few minutes. Obviously, if it starts to bleed, we'll blow it back up to that 14 cc's, and then leave it on for another 30 minutes. I would say vast majority of patients don't need that extra time, even with the blood thinner or low platelets.
Yeah. Another question. You know how you have the tubing going towards the opposite of the fingers. Would it matter if you flipped it?
The TR band?
Yeah. Say you went 100, like flipped it the other way.
Yeah, the problem is the balloon is going to be on the wrong side, right? If you flipped it the other way.
Correct.
Because the balloon's only on half of the TR band.
It's not really. It's not really in the middle.
Gotcha.
It's on the side. Yeah, so it has to be that way. So it's actually, technically speaking, it's actually upside down because it's designed for right radial. So it makes it a little bit hard because there's actually a window to see into the spot of where it's bleeding. It's opposite of where it should be if it were doing a left radial. So it's on the right side if you're doing it on a right radial approach, but it's fine. We've been using this for a long time. There are other ones that have like a ratchet mechanism that you sort of screw down and things like that. So there are different ways of doing it. The other thing we do is we monitor the perfusion of his hand. So we keep our own pulse ox on his left thumb. And there's a good waveform, so we know his hand is well perfused. We do feel a pulse distally, so I'm not really worried about his hand perfusion or anything like that. So.
Yeah,
and that's sort of how we monitor our access. Yeah.
Important point. Yeah, that's patent hemostasis. So there's two ways that he's monitoring. Sometimes you can't feel the pulse exactly because maybe you accessed a little too low and your TR band is over the distal or over the wrist or distal forearm, but you can always put on the O2 sat monitor. And if you have a good waveform, it's perfusing. So.
Yeah, I appreciate Rahul's expertise in this. When I was starting to do these, I always text him or call him and go, "Hey, what do I do now? What do I do? What's the orders?"
Yeah. But once you get going, it's actually pretty easy, and patients really like it. So, yeah.
Let me add one other question. I've seen people do this kind of snuff box or distal radial. Do you use it, and if so, when? Why?
We haven't used it a lot. We did for a short period of time try to use the snuff box access. People say it's more comfortable. I don't know if it's safer or anything like that. It's just you don't have. So if his hand is turned with his palms up, so a snuff box, in terms of a positional standpoint, you can leave the hand sort of a more neutral position with the hand up. I personally, we haven't used it a lot, so we didn't find it super helpful.
I use it in like a case that comes to mind. A patient who has a tumor and can't really rotate their arm, and I want to go ipsilateral. That's when I've used it, but not. And there are specific closure or bands for that.
Yeah, you do have to use a different. You can't use a TR band for that. You have to use something else. Yeah.
This is an awesome case. I did like
the
combination with the large coil mass and then the intermediate coils. Now I guess it used to be the largest coils like microcatheter, but now you have the intermediate, the large, and the small, the LP. So. Nice to have. Great case.
Great result, Joji. Thank you for being here with us today.
Thanks for Joji.
Ishan and Rahul. Thanks so much. I'll let you close, Rahul.
No. Thanks to everyone for joining us, and thanks again to the whole team for making these cases go smoothly. And we'll see you next month.
Okay.
Bye, everyone.
Thank you.